some questions about the contract. It's definitely being cut February 28th, so that affects Mike Booth, Sue Love, Heather Atamian, and myself. So we'll see what happens, you know. I learned after busting my tail in the military for 24 years, thinking I was important, I was going to make all these changes for emergency medicine PAs, and I increased our numbers and increased our billets and tried to increase our rank and try to give us a bonus. And I worked all the way up until the day I retired. I had like 60 days I had to turn back in of leave that I didn't use. And guess what happened the day after I retired? I was completely replaceable, just like we all are. We're numbers, bodies, you know, even though we have value and worth and we're not always treated that way, all of us are replaceable, okay, in positions. So that can be a double-edged sword, right? The message there is try to do some work-life balance for yourself as much as you can while you're in the military, because it will suck every ounce of you. And in the back of your mind, just remember I was told once I'm replaceable. So when you're neglecting your family and your body and everything, you know, try to advocate for yourself to have that work-life balance a little bit, because unfortunately, you can't do this forever, right? And your military time has an expiration date, so family hopefully doesn't, your health, hopefully it will, but hopefully it'll last long. So this morning, we're going to talk about chest pain, and you know, some of you are really adept, I learned the other day at ECG. Some of you really picked it up, maybe from your prior life before IPAP, maybe because you just really grasped the material during last semester by Dr. Love. Maybe for whatever reason, you know, some people get it. I personally never had blocks as a child, so this didn't make sense to me as I went through IPAP, okay, because they literally are comprised of little blocks, right, so I just didn't register. So today, I did have a few people come up to me and said, you know, I'm just not really tracking. Some of you are, so those of you that are real adept and just such a professional, knowledgeable ECG person, bear with us, be patient with me and your colleagues as we all try to come up to the same place in our learning situation. I incorporated some extra practice cases at the beginning of this lecture. We're just going to go through them real slow. Make sure you have a good grasp. It's going to make you successful for our exam in a few weeks and in life, because you may not be an emergency medicine PA, you may not ever want to look at anything emergency the rest of your life, but unfortunately as a PA in a family medicine clinic, even a derm clinic, you know, somebody can come in with chest pain and there's an ECG machine. So some basic stuff needs to be kind of comprehended and maintained. Any questions about anything we covered the other day? I know we blasted through some of the other lectures that some of you hadn't listened to yet and probably still haven't, because I understand there's 15-meter targets. But I kind of wanted to hit some highlights. But I'm here and available for any additional questions. Anything from the ECG overview the other day? Anything confusing or contradictory from what you were learning previously? No? Where's your energy today? Huh? I need you to bring it. Usually the 10 a.m. is the sweet spot. You know, it's not quite 10, but usually that's the sweet spot, and for like 24 minutes, okay? And if I'm not done by then, I've lost you, right? Okay. No insult to your attention span. This is the way adults just learn and don't learn. So we're going to talk about approach to the patient with chest pain. So we have this saying in emergency medicine, if as you're approaching a patient, if you don't think about a diagnosis in your differential, you'll miss the diagnosis. So when we're reading a chief complaint on the tracker board of an emergency department, it says chest pain. Give me some differentials right off the bat that you should just, before you even walk in the room, that you're thinking. Of course, acute coronary syndrome, or MI. What else? PE. Dissection. Okay. What's that? GERD. It could be something GERD, right? I mean, we see a lot of GERD. What else? Okay. Yeah, it could be something musculoskeletal, like a costochondritis. What else? Could be a pneumothorax, spontaneous pneumothorax. What else? Could be an anxiety attack, right? I mean, trust me, when I see 18-year-old chest pain / anxiety, I'm like, great, okay? What else? Could be tamponade, right? What's another bad killer that we need to think about? Some killers. Think about killers. Sudden onset. You said AAA, but in terms of chest, it's dissection. But there's another. What if I said somebody was vomiting, an alcoholic was vomiting? What's another one? Or Hobbs or esophageal rupture. Okay, good. So we said tamponade, we said pneumothorax, which tension, we said ACS. There's some other things to think about infectious causes of chest pain. Pneumonia, very good. Influenza, pericarditis, pleuritis, very good. You guys are nailing it, okay. I know you want me to drop the mic, but not yet. Okay, so here's some of the references. I know that you guys diligently read Tintinelli at home, so I'll let you know which chapters. These are chapters 48 and 49. I also put a little blurb in here from MRAP. If you do want to go on emergency medicine, this is where every month they publish like the latest information. They go over papers for evidence-based medicine. It's a really good source, and they have a way of summarizing things pretty quickly, so it's nice. So I did add some extra information, and for those of you that can't get on this site, I actually gave you a reading version PDF of all of this PowerPoint on Canvas, okay? I know some of you use AI, and you just extract the material and make it into a document. Does anybody do that? Not yet? Some people do. Okay, you take my whole PowerPoint and it'll extract everything into just like salient points, hit the highlights, and a lot of people are successful that way. You may miss a few things. Because AI is not as smart as you yet. Well, I don't know, maybe. Anyway, so here's some things we're going to talk about. We're going to talk about how do we approach somebody with chest pain. I mean, what do we do? We're thinking all these crazy things, casting a wide net, where our idea is to narrow that down to a definitive diagnosis. And we always talk about a safety net in the emergency department. That's how we protect ourselves, and that's how we get our patient ready for treatment. And one of those, what's that safety net we talked about before? IV O2 monitor. If they present with chest pain, they're supposed to get an ECG within 10 minutes, okay? That's a national metric. Very good. That's our safety net, all right? And then here's 6 causes of chest pain you should always, always consider in anybody who presents with chest pain. All right, 3 of those we can rule out right away, but 3 of them we cannot. Which 3 can we rule out right away, like with just a quick physical exam or bedside ultrasound? Which 3 of those can we rule out? We can definitely rule out tension pneumothorax with a bedside ultrasound, okay? If they don't have a pneumothorax, they can't have a tension pneumothorax, right? What's that? Tamponade, same thing, bedside ultrasound. Do I see a large pericardial effusion with right ventricular collapse? No, boom, it's definitely not tamponade. What else can we rule out? Rupture, right? They haven't had a history of vomiting and they seem like a reliable person. There's no crepitus when you touch them and stuff. They probably don't have BORHOBs, all right? But so right away we can rule out those 3. So these 3 are the ones that are going to require a workup. How do we work these 3 things up? Are they all the same? Do we just work everybody up for all 3 all the time? Yeah, so definitely that ECG in 10 minutes. And what's the whole point of getting that ECG in 10 minutes? What quick thing are we supposed to be able to identify? STIMI, right? Everything else, it still could be an NSTEMI or acute coronary syndrome, which is also unstable angina. But it's our responsibility to look at it and say STIMI or no STIMI right away. We've got 10 minutes. Good. All right, how do we rule out? So that's STIMI by looking at the ECG. How do we rule out other forms of acute coronary syndrome? How do we rule in or out an NSTEMI? What is that? That's not necessarily, it could be a normal ECG or maybe some ischemia, but we rule that in by biomarkers. And we rule it out by biomarkers, i.e. troponin. Okay, how do we rule in or out unstable angina? How do we rule it in or out? They should have a negative ECG, because if they didn't, then that would be probably an NSTEMI or STEMI. They should have negative biomarkers, because by definition that would be an NSTEMI at least. So how do we rule in or out unstable angina? Just history. It's your gestalt, okay? It's your intuition that this patient is showing signs of progressive occlusion by their symptomatology. So that's a clinical decision, but you've ruled out the other 2, okay? PE, how do we rule PE in or out? I know we haven't had our PE lecture yet, but how do we rule it in or out? D-dimer, if it's positive, CT angio, okay, of the chest, okay? It's a PE protocol. Very good, okay? Aortic dissection, how do we rule that in or out? I'm sorry? So, quick bedside, we're going to check for bilateral pulses. I always think, and we haven't had our dissection lecture yet, but aortic dissection to me, and it should be also to you, is chest pain and something neurological. Chest pain and arm weakness. Chest pain and Horner syndrome or hoarseness. Chest pain and stroke-like symptoms, okay? It's a chest pain plus something, and we rule it in or out by a CT aortogram, which is different than a CT angiogram, but they're kind of the same because they're CTs with IV contrast, but some people call them synonymous terms. The good news is, and this has happened to me, I'm like, this person definitely has an aortic dissection. I talked myself into pulse discrepancy, sudden onset, tearing, ripping pain, radiates to the back. I'm like, this is definitely a dissection. So I did a CT angio of the chest, which also included the aortogram. They even do runoffs where they actually will ultrasound all the way down to the iliacs, which is awesome. So it came back positive for PE. And I was like, nailed it, okay? The whole time I'm like, this is definitely dissection. I got the right diagnosis by the wrong way. So, hey, sometimes we're lucky, and it's nice to be lucky, right? Okay, so these are the things we're going to talk about. So, take-home points. This is a busy slide, and the reason why I put it up front is because they say as adult learners, you only remember the first few things somebody tells you and the last few things. And in between, nobody knows what happens to all of you, okay? The GCS 12, 13, I don't know, laundry lists are being made, important life decisions, you guys are seniors, you're moving, all kinds of things are happening. So let's talk about this. So we talked about acute coronary syndrome. What does it encompass? 3 diagnoses is acute coronary syndrome. All of them are acute coronary syndrome. Which 3? STEMI, NSTEMI, unstable angina. Very good. ECG in 10 minutes, and we always get IV access, right? Because we need to start treating them if they do have a STEMI, all right? We're looking for ST elevation. That's what we're on the hook for in that first 10 minutes, but some clues to NSTEMI would be something like ischemia or ST depression, okay? Other classic findings, which we'll talk about. Here's a little pointer for you. If somebody comes in and it's been less than 6 hours since the onset of their chest pain, you can't get away with ruling out an NSTEMI with just one troponin. You're going to have to do what we call a delta troponin, which is this fancy term. You know, delta means change. It just means a repeat troponin in a few hours. So we do an initial one, and then we repeat it in 2 hours. Why is that? It takes a while for troponin to leak out of the heart after it's been injured and be detectable in our bodies. Even though our high sensitivity troponins now are really amazing, they pick up everything. But let's say somebody just came in, like I just walked over here and I have severe crushing chest pain, sudden onset. You do a troponin on me, it's going to be negative, okay? You repeat it in 2 hours, it may still not meet criteria for positive, but if that second one is significantly more than my first one, I'm trending up in the wrong direction and I'm probably having an NSTEMI. Okay, so if it's been less than 6 hours, you can't get away with ruling out NSTEMI with just one troponin. Don't let them go home. I've seen patients come in, they're like, yeah, I was seen a few days ago for chest pain. They said everything was fine, but I just don't feel right. And you'll do a troponin on them, and they have downtrending troponins. Like they've already had their MI, and it's already starting to downtrend, so that's bad, okay? And we miss a lot of chest pain or ACS patients, believe it or not, in America. Okay, not you, they miss it, okay? All right. So that's what we do, the repeat. Delta, a lot of people get confused about the term. That just means repeat. Some people think, is that a special troponin? No, it's just a repeat. It just means delta, like the change over time. Risk stratification for low risk chest pain. We don't do risk stratification for people that we know have a STEMI or NSTEMI. What do we need to risk stratify? They're having a heart attack. Okay, they come in, unstable angina. They might do some risk stratification for unstable angina, but for low risk chest pain, we're trying to decide, can I send this person home or not? This is when the heart score comes in. Have you guys learned the heart score? Have you heard about it? Okay, you definitely need to know it. It's good stuff. And this is how you can justify, hey, this patient's score is 3 or less, I can send them home. 4 or greater, just bring them in. Get them a workup, okay? It's real easy. All right, you guys learn this. Door to PCI, 90 minutes if you're at a PCI capability facility. What does that mean? I mean, somebody comes in, they have a STEMI. I'm at BAMC, which is a PCI capable facility. How many minutes from the time they walk in the door do they have to get to the cath lab, which is PCI, percutaneous coronary intervention? 90 minutes. So it's not 90 minutes from onset of their symptoms, right? It's 90 minutes from the time they walk in the door. So if grandma started having chest pain last night, she doesn't come in until the next morning, I still have my 90 minutes, even if it's been a long time. Okay, for a metric. Now what if I'm working in Uvalde, like I did last night, and I have a STEMI patient and there's no PCI capable facility right there. I have to ground transfer grandma from Uvalde to one of the hospitals here in San Antonio. How much time do I have? They say 2 hours. What is better, PCI or thrombolytics, also known as fibrinolytics? They're the same thing. PCI is definitely superior. So if I can't get grandma because it's an hour and a half, especially last night with the fog, 2 hours from Uvalde to BAMC, it's going to be like 2 hours and 20 minutes. Do I risk giving that fibrinolytics to grandma, or do we take the 20-minute hit? Yeah, that depends on the cardiologist. I would have a close conversation with that person, okay? Because PCI is superior. So if you're pretty close to the timeline, PCI is always going to be superior. But if it's 12-hour delay, like when I worked in Brady, Texas, out in West Texas, middle of nowhere, it was like a windstorm. The only way you can get patients out of there is by helicopter, and like all the birds were grounded. Even fixed-wing aircraft were grounded. I just had to sit on an MI and do the fibrinolytics and just watch them go through all those crazy rhythms that happen afterwards, and just like, please don't die, please don't die, please don't die. So it just depends on your facility, but PCI is superior. If you're deployed or stuck in a situation, you have to do the thrombolytics, also known as fibrinolytics. We're going to do it. Okay, we're going to talk about that. Okay. How do we treat STEMI and STEMI acute coronary syndrome of any sort, unstable angina? How do we treat it? Everybody gets aspirin, okay? No people that don't get aspirin, or people have aspirin allergy. Everybody gets aspirin, whether it's a STEMI, in-STEMI, or unstable angina, everybody gets aspirin, all right? Everybody gets heparin, okay? So we do our own little version as clinicians of PCI. This is my own little stupid acronym. This is how I remember stuff. I know that the definitive treatment for all acute coronary syndromes is percutaneous coronary intervention, right? For everybody, STEMI, in-STEMI people, they just don't have to have it right away, but they'll get it in a few days. Everybody gets PCI eventually, okay? That's the definitive treatment. That's like a chest tube for a traumatic pneumothorax. Everybody gets a chest tube, all right? Everybody gets PCI at some point. It just depends on how soon, okay? We, as clinicians, do our own version of PCI, just so you can remember. We're gonna stop the platelets with aspirin. We're gonna stop the coagulation with anticoagulation, like heparin. And we're going to stop the infarct size with nitroglycerin. Have you guys been taught to do that for everybody? Do it for everybody, okay? Everybody gets those three things, all right? The only difference is a little dosing difference with the heparin, but everybody gets those three things. Everybody, okay? So that makes it easy. So it doesn't matter if it's a STEMI or in-STEMI, you already know how to treat it, right? And then I'm going to talk to you about how much of everything and when to give it, okay? Definitive treatment is PCI for everybody. Have you learned that before, that they actually do PCI for in-STEMI? They do. How long do they have to actually do the PCI for the in-STEMI people? Yeah, there's no definitive time, but usually they try to do it within the next 2 days or so, 48 hours or so. All right, so why is this such a big deal? Because in the US, a bunch of people have a lot of comorbidities, and on average, in the ER in the US, we see about 7 million presentations of chest pain per year, and yet 2% of people who are having heart attacks, it's still missed, okay, that's bad. In medicine, an acceptable amount of risk should be less than 1%, okay, so this is bad, we're not doing great. So let's do some warm-up cases. I'm going to go through this slow, okay, just so those few people that are straggling behind or aren't clear, I want us to understand, and then couple it with the vignette and kind of walk through it, okay? Do I need to read the vignette to you? Come on, bring your enthusiasm. Show me your ECG prowess today. You guys have an exam Friday? Yeah. Okay. No. Never. Don't worry, I'm going to dispel all those rumors. I'm going to make it so easy for you that you're just automatically be like, PCI, platelet coagulation, nitro to stop the infarct size. I don't think anything else, because everything else is bad. Okay, warm-up case. 78-year-old male complains of chest pain, so they get their ECG in 10 minutes. EMS gave him 324 milligrams of chewable aspirin en route. How is that possible to give 324 milligrams of aspirin when they're 325 milligram tablets?
4 babies.
4 babies equals 324. Very good. Okay. Vital signs are a little bit low in the blood pressure, right? 94/66. Heart rate's 102. Respirations are 16. Unlabored. Pulse ox 98% of room air. Well-nourished, well-developed male. Moderate distress, okay, because of chest pain. And based on the ECG below, which of the following is the most appropriate next step? Don't you love it when instructors pose a question like that? What's the next step? What do you guys think? What's the next step? So let's go through this together, just to be clear. Okay, so remember I told you systematically you should always do rate, rhythm, axis, morphology, look for ischemia and STEMI. So rate, just to remind those of you who don't remember, and those of you who know it, just bear with us, okay? We're going to find a QRS complex on one of these big squares, right, and try to get one that's right aligned with that. And so the easiest way that I do it, besides the fact that most ECGs will tell you what the rate is that you count squares over. So from this QRS complex to this one, I'm going to go the rate, if it was right here, the next one would be 300, 150, about 100. So the heart rate is about 102. That's right, right? You guys agree?
Yes.
You remember how to calculate rate? Everybody with me? Don't be ashamed to raise your hand, okay? All right, rhythm. Okay, do we see a P before these QRS complexes?
Yes.
And does it look regular?
Yes.
So it's sinus because it has a P wave, which is the atria contracting between the QRS, and it looks pretty regular. So rate, rhythm, what's the axis? We're looking at leads 1 and F. Are they both upright primarily, 1 and F? That means normal axis. All right, rate, rhythm, axis. Now we're looking at morphology. Again, we're looking at anatomically contiguous leads. So anatomically contiguous, what goes with lead 1? So yeah, with lead 1, which is the lateral part of the heart, it goes with ABL, B5, and B6. Do we see ST segment elevation or depression? Depression. We see it in 1, okay, because this is the ST segment and it's below baseline. It's here, it's below here. How about 5? Is it ischemic there? Not so much, right? How about 6? Do we see some depression?
Yes.
Yes. So we have some ST depression in the lateral leads. Now let's go to the next set. Contiguous anatomical leads. So leads 2, 3, and ABF right here go together. Do we see ST segment elevation or depression?
Elevation.
Way elevation. I mean, you can see it from the offices next door, right? I mean, this is a lot of elevation because this is the little P wave, this is the QRS, and it's just really large. It's a lot of elevation. And by definition, it only has to be how many millimeters? Only 1, which is one little tiny box. If you can see up here or look on your screen, there's 1, 2, 3, 4, 5, 6, 7, almost 8, 9 boxes, right? So that's a lot of elevation. All right, so we've got contiguous elevation in 2 contiguous anatomical leads, actually all 3. So this is an inferior STEMI because of that. We already know that. But let's not stop there. Right now I'd be like, code STEMI, fancy, code STEMI, and that's how they do it in a nice like radio DJ voice. Okay, I don't actually say it because my voice is ridiculous, but they do it. Okay, so anyway, so 2, 3, and F. Okay, so now we're going to go through. Does ABR matter? ABR used to be the forgotten lead. It actually does matter. Okay, so look at it, but you look at it all by itself. Do we see anything about ABR here? I see some depression, right? It's below baseline. If you look at the ST segment, it's a little depressed. Okay, we've already looked at ABL and F, so now look at the V1 and V2 are technically septal. I, the other day, kind of just crammed them into anterior heart because that's all left anterior descending artery. Okay, I just kind of crammed it all in. And some set of people it might be a little different, but anyway, V1, V2, do we see anything there? Depression? How about the rest of the anterior, V3, V4? I'm sorry?
3S, 4 maybe?
Yeah, exactly. I don't, maybe not enough to make 1 millimeter in 4. So this is a clear-cut inferior MI with a lot of reciprocal changes, especially in the lateral, septal, and anterior leads. So this is a massive inferior MI. And what did I tell you the other day when we're looking at this? How can we tell that Is it an inferior MI or inferior MI with right ventricular extension, and why does that even matter? So the difference is the lesion in a right ventricular involvement MI, STEMI, is that the occlusion is really high up in the RCA. So it knocks out the conduction system in the entire right ventricle. And what happens if you knock out the entire right ventricle? You can't hold the stuff that's needed for the left side, so they go into major cardiogenic shock. Okay, it's bad. All right, you get pump failure. They're preload dependent. Those are the people you can't do nitro and stuff. Remember those little clues the other day? I said if 3 is greater than 2, that's an indicator that this patient has right ventricular involvement. Is there anything else just in the vital signs that are kind of already cluing you in that this might already involve the right ventricle and not just the inferior part of the heart? The blood pressure, right? And are we going to give this guy nitro? No, remember I said everybody gets aspirin, heparin, and nitro, but this would be one person that we're going to be cautious about. We're going to give him fluids, get that blood pressure up first, and then reassess. Okay, really good. So back to the original question now that we've gone through all of that. And the only reason why I picked on this side is because that's where the camera is, so I'm going to do my pointer, because there's really authoritative stuff happening over there. But I'm not ignoring this side. So to go to the original question, what's the most appropriate next step? You want to do a right-sided ECG, still call the code STEMI. Okay, if it's a blatant STEMI, you're going to call it if you're at a facility. If you're in Uvalde and you call it, nobody's going to listen. So just make sure you get the right-sided ECG. Okay, you guys nailed that. Good job. All right. So this says code STEMI, activate the cath lab. Okay, if you're not at a PCI capable facility, you're going to do a cardiology consult immediately while the nurses or medics or whoever are doing the right-sided ECG. If you're at a non-PCI capable facility, you're going to start going down your fibrinolytic checklist. That's who do I not give fibrinolytics or clot busters to? Who would you not want to give them to? Just common sense. Anybody who's bleeding, right? It doesn't include a female out of NCs, but otherwise, if they have like a GI bleed or a major lesion in their brain or just had a hemorrhagic stroke, those people are probably, it's just common sense, okay? But there is a checklist, so you can go down it. You don't have to memorize it for my exam. Yes, sir?
Is heparin still happening on this patient?
Heparin? Absolutely. STEMI? Heparin,
So,
yeah. And you may ask yourself, a lot of people are like, well, why? Why would you take a risk? So heparin's a little bit different. That's going to keep you from just making new clots. Thrombolytics like tenecteplase, streptokinase, they go in there and bust up the clot. So you might be asking, why would you put a patient at risk for bleeding during a cath procedure with a blood thinner? And the reason is that when they're going in there doing PCI and they're scraping the coronary arteries and getting that clot out, what are they doing? They're creating microtrauma. And how does our body respond to those little bleeds and microtrauma? Get platelet aggregation, clot formation. So, we have to minimize the risk later of what's happening during the PCI. So that's why they get aspirin, that's why they get heparin. Yes?
Man, if the patient can't answer those contraindication questions, would you just give it?
Ooh, I would try really hard to get into PCI because A, PCI is superior, and B, I've unfortunately seen people who met the criteria have catastrophic brain bleeds and they are in a vegetative state. So in our attempt to save their life from their STEMI, we have killed them, so it's not a decision to be taken lightly. So I would definitely do that in concert with somebody else. Make somebody else responsible for that decision. That's my recommendation. Call a cardiologist. Yes, ma'am.
So in like the rural hospitals, like they're contributing to fibrinolytics, but they can't make it to PCI in time, or they just have luck.
Yeah. It's just bad circumstances. Maybe they made a lot of poor choices that have just come, caught up with them. All right, maybe they're bad genetics, maybe they're bad choices. You just do whatever you can, do the rest of the full court press that you can and support them and try to support them through their dysrhythmias. That will be happening. Yep. Or cardiogenic shock or whatever ensues. Very good. All right, so this is what we do. Code STEMI, cath lab, fibrinolytics. If you're not, assuming they meet all the criteria and that you can't get them in a reasonable amount of time. And then lastly, if you are at a PCI capable facility, 90 minutes to cath lab, okay? In that time while we're waiting, we do aspirin, we do heparin, and we do nitro. And this particular patient, he's already hypotense. I would probably withhold the nitro for a little while, see how they do, all right? And that goes for morphine. Morphine's bad for MIs, so I'm sorry if you're taught Mona Mona B, that's gone out like 10 years ago. There's no more morphine associated, I'm sorry, I'm not trying to confuse you or contradict anybody. It's been a fundamental conversation, but there's a Crusade trial, you can look it up yourself. And that's the part of you guys being responsible clinicians, is that you have to interpret the data yourself. There's people with MIs have poor outcomes when they're given morphine for pain because of the preload situation and all of that. We'll talk about that later, okay? Yes?
Is it the same thing with Rigor?
So clopidogrel is an antiplatelet, and a lot of times what we do and what we're responsible for is aspirin. If the cardiologist wants the clopidogrel, they will ask for it. You could give them multiple antiplatelet, and usually what they do is at the time of the PCI, they will give them dual antiplatelet therapy. Or sometimes they'll get through the PCI procedure and do it right at the end, and that's when they initiate the beta blockers, ACE inhibitors, all that happens after cath lab. You don't do it in an ER setting because it actually worsens their outcome and infarct. Okay? Okay, you guys with me? You guys need a break after that? Are you emotionally exhausted? You are? Dude, we're gonna plug through it and run this together. All right, I got a thumbs up, and that's all the affirmation I need. Yes, sir?
If you weren't going to do morphine because of the Crusade trials, but the patient's in significant pain that the aspirin is not handling,
Right, aspirin won't. It won't be, it's not a very good
then
analgesic.
what are you doing for a patient?
Very good question. So the way that we limit the infarct size is with nitroglycerin. Nitroglycerin actually helps reduce the spasm, should help reduce their discomfort, open up and improve the coronary blood flow, which is the source of the pain. So that should help them. So a lot of times we'll do an initial dose of nitro followed by a nitro drip. But in the case of a patient like this who can't have morphine, can't have nitro because it's right ventricular involvement, we're going to give them lots of fluids, first of all. Some patients with inferior MIs need up to 10 liters of fluid. That's how much preload dependent they are and how much fluid they need. So we're going to give them fluids, and you can do a more safe drug like fentanyl, which is more hemodynamically stable. Low doses, 25, 50 micrograms of fentanyl is safer. Okay, very good question, because we do want to address our patient's pain, absolutely. But the nitro by itself, actually, some of the experts say that should help decrease the pain if you're able to give them. So if you give enough fluid to support their blood pressure and they come up normotensive, you can start titrating a nitro drip, put them on a slow drip, like not high dose, put them on a slow drip, titrate it to effect. If they become hypotense, you just shut the drip off. So, everybody with me? Is this like blowing your mind, or you already know all this stuff? Okay, I'm just gonna pretend I'm blowing your mind because it makes me feel better. Okay, all right, case 2, 80-year-old man, presents to the ED, of course with chest pain. I'm gonna show you an ECG. What's in our differentials? PE, what's the 3 bad ones? PE, dissection, ACS, good job, you nailed it. Okay, I'm gonna let you guys go through this systematically, all right? And I wanna keep taking up your whole time. Somebody tell me rate. We got a QRS complex here, so there's one box, so that would be 300, 150, 100, somewhere between 75 and 100, so 80 something, right? What's the rhythm? Is there a P before the QRSs? Okay, it's a sign, is it regular? Okay, what's the axis? Okay, it's normal. Morphology, which is what we're on the hook for. You guys got this. Say it with conviction. This is boring. I gave you 2 inferior MIs back to back. Okay. Anything special about this one? Is lead 3 greater than lead 2? So probably right ventricular involvement as well. So very cautious. So again, this is MI, RCA lesion. He had acute chest pain, ST segment elevation in 2, 3, and F. He also had depression greater than 1 millimeter. Where were those reciprocal changes on this ECG? Yeah, kind of lateral, just 1 and L. But they don't have to have them. Remember, 30% of MIs, STEMIs, do not have reciprocal changes. Okay, very good. So this is 100% occlusion at the RCA. Case 3, 65-year-old now, ED with chest pain. Here's the ECG. In your vignettes, I'll give you more information. I'll give you vital signs, I'll give you onset and comorbidities. You guys are getting down the rhythm of the ECG reads, right? So let's do rate. 300, 150. It's a pretty fast rate, right? I see a QRS complex on this big box. I'm gonna count one over, it's not there, that would be 300. This is a rate of 150, it's pretty fast. Is it regular? Kind of hard to see, there's a little ectopy, huh? Is there a P wave before the QRSs? Yeah, so it's at least a sinus rhythm. What's the axis, 1 enough? 1 is upright, F is not. Well, so is depression, right? Okay. What's the morphology? Very good, that's an anteroseptal. And if it's anterior and septal, where's our reciprocal changes supposed to be? Inferior? Which is where it is. Okay, good, awesome. So this is ST segment elevation V1, V2, which is the septum, V3, which is anterior, and they're anatomically contiguous, so this is synonymous to STEMI. All right, we want a little break right now? It's been 45 minutes. I know it felt like we just got here, right? Or maybe it's only been, it's been like 45 minutes, right? We started by 9:30, 9:40. Hey, if you're not ready, I could go all day. Let's go. Let's do this. All right, acute coronary syndrome. Okay, some of this is redundant, and I put a lot of extra stuff at the end, so it seems like a really tedious, long lecture, but there's a lot of repeat information that we're already talking about. So acute coronary syndrome, we know it encompasses 2 things. They either have acute myocardial infarction, whether that's a STEMI or InSTEMI, or they have acute ischemia, which is what we call unstable angina. These 2 we rule out by ECG and biomarkers. This one is a clinical diagnosis. We have to rule everything. We have to rule this out, and then they still have a very suspicious story of, worsening dyspnea with exertion, chest pain, all those little indicators that it's unstable angina now, not the baseline chest pain. No remarkable ECG changes, and we don't have obvious myocardial damage by positive biomarkers. You agree? All right. So what's the difference between the stable and unstable angina? Tell me the difference. What's happening within the heart and the vessels to make it stable versus unstable? Yeah, so the patient has a certain amount of exercise tolerance or intolerance. For instance, grandma says, hey, I have to walk a quarter mile to my mailbox. I can walk down there, but by the time I get down there, I start getting chest pain. I'll sit on my little bench for 5 minutes, able to get the mail, and I can make it back. I've been doing that for years. That's stable angina, right? But if all of a sudden grandma says, no, I used to walk to the mailbox every day and back, and now all of a sudden I'm starting to have chest pain when I do it. That's unstable. So physiologically, is that stable angina has a fixed atherosclerotic lesion in there. It's fixed. It's just there. It's staying there. All right. When it becomes unstable, it changes. It either gets larger, maybe it's causing some spasm around the coronary artery, or maybe it's actually disrupted and embolized. Okay. All right. You guys heard the word pathophysiology, and I lost you. It was just like that, instantaneous. Okay. So an ACS, that plaque ruptures, and then they get a thrombus that develops. So it actually gets worse, right? And so then the coronary blood flow is suddenly reduced, causing ischemia. And if we don't intervene while it's ischemia, it progresses to infarct. And you guys know the difference, right? Ischemia we can actually intervene on. That's where we see the ST depression or T-wave inversion sometimes. If we can intervene and get in the right stuff and open up that coronary artery, we have less damage control to do, okay? So here's a little cartoon about what's the difference between hypoxia and ischemia, or which is ischemia versus complete 100% coronary blood flow occlusion, which is what happens with the STEMI. It's 100% occlusion. All right, so initial assessment. Somebody comes in, they look sweaty, and they're crushing their chest with that sign that they do. What's that called? Levine sign, right? And they come in. What's our safety net? IV O2 monitor. What do you think a cardiac set of labs are for somebody who's suspicious for acute coronary syndrome? Troponin, definitely need a biomarker. We need an initial one right away. Okay, what else? Why would we do a metabolic panel? Yeah, we need to know everything, right? Because the more electrolyte abnormalities they have, and a lot of times we'll do a complete metabolic panel, and we also include mag and phos, because the more electrolyte abnormalities these folks have, the more apt they are to have worsening dysrhythmias, which are a complication of the MI to begin with. Plus, we have to know their kidney function status, coagulation status, things like that, if we're gonna be doing things like thrombolytics and heparin, all right, that's important. All right, good. What else? What other kind of medication, labs? What's that? Yeah, BNP, right? There's a degree of cardiogenic shock that happens with all MI, and so we need to know the brain natriuretic peptide. Why is it called a brain natriuretic peptide when it's found in the ventricles of the heart? When they first discovered it, they discovered it in porcine brains and called it that, but it actually originated from the heart. And I don't know why they didn't rename it. They should have renamed it, right? That's one of the things they should rename. Okay, all right, what else? Yeah, so CBC, why CBC? Yeah, maybe they have an underlying of infection or anemia. Maybe they're in a high output cardiac failure which caused the MI to begin with. Or maybe they're having sepsis and they're causing what's called a type 2 in-stemming because the underlying sepsis has put such a strain on their heart that now they're having an in-stemming. We see it all the time. Okay, and then of course coags, PTINR, and then plus minus D-dimer. Okay, what's a plus minus D-dimer? Who would you do that on? Only if you suspect that an alternative diagnosis might be PE. Otherwise, don't do it. Okay? All right. Identify and treat the life-threatening stuff, right? ABCs first, and give O2 only if their oxygen saturations are less than 90. So we used to be taught Mona B. Was that what y'all were taught? I'm old. They definitely was like Mona, morphine, oxygen, nitro, aspirin for everybody. And now they're saying, actually, don't give too much oxygen. Hyperoxygia is bad for the patient. So don't put everybody on it, but put them on it only if they need it, or if they're short of breath. It just seems like you should help them, but it doesn't necessarily help the heart if it's too much. So oxygen if they need it. All right, pearls, okay? Again, DORA to ECG, how long? How long do you get to interpret it as a provider? Not 10 additional minutes. You're supposed to have it done and interpret it within a few minutes of a good job. We're going to get a quick history and physical exam. We're going to look at the ECG, decide if it's a STEMI, see if there's any ischemia or other findings, and then move on. If it's not a STEMI, but we still have a high suspicion, what are we doing? That other workup, right? Depending on onset of symptoms, repeat troponin, repeat ECGs, things like that. Okay, so give me some examples of classic chest pain. Classic, what you guys are taught besides the Levine sound. Crushing. What's that? Radiating. Where does it radiate? Shoulder, jaw, what else? Nausea. That's especially true of our inferior MIs, right? Because the inferior part of the heart sits against the vagus nerve. You get vagal stimulations, they get diaphoretic and nauseated, sometimes they actually vomit. Okay, what else? Classic. Exertional chest pain. So you guys get confused sometimes because you guys, not you, maybe previous classes, you guys are smarter than previous classes, but previous classes got confused because they thought exertional chest pain was less severe than chest pain at rest. And they're thinking about the New York Heart classification of heart failure and stuff, but if you're exerting yourself and that's when you get chest pain, that's acute coronary syndrome. If you have chest pain while you're just sitting there watching TV, do you really think the heart's working that hard and got ischemic all of a sudden? I mean, literally, probably not. No, I mean, unless you're super excitable, like I was when I was watching the Chiefs game, okay? I mean, maybe that could entice an MI, but probably not. So this is all this classic stuff. So just to be clear, diaphoresis, nausea, vomiting, dyspnea are also symptoms of classic MI. What are some non-classic?
So it's not, go back to that last one, it's not worse.
So by New York Heart classification, heart failure is worse if you have symptoms at rest. But people who have chest pain at rest, just sitting there having chest pain, that's not a coronary artery lesion causing the discomfort. There's no way that the heart, remember, we have episodes of occlusion because of increased myocardial demand. If you're just sitting there watching Jeopardy, there's no increased demand happening. Just if you have increased symptomatology and you have a history of heart failure, now your symptoms have progressed to the point where you used to be able to walk around before you got short of breath and now you're just sitting there short of breath, that's heart failure. Exertional chest pain is ACS until proven otherwise.
One's ACS, specific one's
Heart failure, that's right.
and that's what it's on.
Yes, sir.
Can But there's that spasm that can happen.
The Prince-Nettles,
Yeah.
that's a tough one. So Prince-Nettles in the ER, we don't always know, we call it as a STEMI. Those are one of the few, when I'm like, call STEMI and they come down and do an ultrasound, they're like, there's no Walrus abnormalities, you're stupid. I'm like, okay, have a good day, sir, you know, because I want their affirmations. Yes, Prince-Nettles a different beast, right? That's a vasospasm that can happen anytime. And it does cause ischemia and it does look like STEMI, but that's a very specific rare condition and that is the exception. Very good. You guys are on top of it. You are impressing me today. I'm just gonna say, what day is this? Wednesdays? I'm gonna ask to let you every Wednesday till I'm fired on February 28th, okay? All right, so non-classic symptoms are what? Dizziness, right? Grandma fell down at the nursing facility. I have heard the gamut. I've heard every time I have a heart attack, my back right here hurts. I'm like, you've gotta be kidding me, you know? So the most important question I ask anyone who's presenting with chest pain is, A, have you had a heart attack before? And if they say yes, I'm like, is this your heart attack pain? Because whatever their anginal equivalent is, should send up your spidey sense that this is severe. So if they say, you know, it's weird, every time I have a heart attack, my right great toe kills me, and I just know it's a heart attack. You're like, you got it, this is definitely an acute coronary syndrome. Even though it doesn't make sense, right? That's a non-classic. But mostly, it's atypical symptoms. Elderly, women, diabetics, they get nauseated. They feel like maybe they get some diarrhea, okay, or back pain. Maybe they just have some dyspnea, weakness, okay. A lot of elderly people just present with weakness. So very non-classic, just to confuse us, just to keep us on our toes, right? Make us earn our paycheck. Again, questions we're asking, hey, have you had a heart attack before? And is this how you felt when you had a heart attack? The answer is yes, consider it serious, okay? Some people are just, you know, they're lonely and they come in and I had a lady just yesterday come in, she was already diagnosed with flu and she's like, I need all kinds of, you know, narcotic chest pain to control my flu pain, you know, and she's a drug seeker, right? And then we have to talk her out of it and stuff like that. So sometimes people will confuse you, but give them the benefit of the doubt. And in small places like Uvalde, we know everybody. So the community there knows each other so much that if there's a call on the red phone, like an ambulance phone, they'll say picking up from whatever street, they'll be able to tell you which person lives there. It's pretty funny. But anyway, point being is that the very atypical symptoms sometimes. So sometimes we get fooled, so we just kind of cast a wide net. Historical factors, exertional discomfort, diaphoresis, if it radiates like those classic findings, vomiting, and then similar symptoms with their prior heart attack. Those are your buzzwords. Are we ready for a break now? Okay, I thought there was a change. All right, so how long do we got? How are you gonna give it, ma'am?
10 minutes.
Okay, we'll take 10 minutes, and then we're ready to think crushing chest pain as an MI or not? No, not really. It's just nice when you apply it to a general population, and especially in family medicine, who you want to try to put preventative medicines on. But in the emergency department, this is just part of their history, but it doesn't mean anything. What's the most important is have you had a heart attack before or known coronary artery disease? If the answer is yes, then this is probably an acute coronary syndrome, right? So helps us in a given population, but not necessarily for ACS. So on exam, what are y'all looking for? We do a quick physical exam. We've seen the ECG, all right, we're gonna call it STEMI or not, right? And then what are we gonna look for them on the physical exam? What are some important things that we need to look for? What do you do for every patient? Heart lungs, everybody, right? And anything we're listening for specifically with the heart? New murmurs, okay? Gallops, muffled heart sounds. Why would it be muffled heart sounds? Could they be having an aneurysm, a coronary aneurysm, and bleeding into their pericardium, presenting with an inferior MI, but really it's a giant aneurysm? That can happen, and it's scary, and the treatment's totally different, as you can imagine. Okay, good. We're gonna auscultate heart and lungs. Why the belly? Yeah, I wanna make sure that we don't hear abdominal aortic bruit, okay? Wanna make sure that maybe they are having a GI issue, have hyperactive bowel sounds. Check extremities for edema and pulse discrepancies. What does edema tell us? Maybe they have a component of heart failure, right? And what about pulse discrepancies? What is that helping us? I'm sorry? Dissection. Dissection. So if somebody has sudden onset crushing chest pain, it could be acute coronary syndrome, it can also be dissection. So we want to make sure, is there a pulse delay from right to left? Radial, femoral, femoral. That matters, okay? So that's important. Remember, the difference with dissection is it should be chest pain and something neurologic, all right? All right, what else are we looking for? Vital signs, right? Vital signs are vital. What of all the MIs can present more often with bradycardia? Which of all is it inferior, anterior, lateral, and septal? Which ones are more prone to present with bradycardia? Inferior, very good. If an anterior MI presents with bradycardia, they're in cardiogenic shock. The anterior, remember, the anterior ones are the big ones. That's the LED lesions. Those are the widowmakers. Inferior MIs, by and large, people do pretty well. If you catch them and you treat them okay, but they'll present with bradyarrhythmias. But guess what? If it doesn't involve the right ventricle, so it's lower in the RCA, and it's just a vaguely mediated bradycardia, so they respond to what drug that we give for bradycardia? Atropine. They actually respond really well. Okay, so that's good. Okay, good. So bradyrhythms, right? Common with inferior wall, which I didn't realize it says that. Anyway, poor prognostic sign. I know my slides so well, I just forgot that one little bullet I put in. I was so wanting to emphasize that point that I actually wrote it. Okay, blood pressure can be normal, right? It can be elevated. What if it's low? Which is worse? Definitely low. That's cardiogenic shock. All right, if they're in an MI and they're hypotense, that's cardiogenic shock. Very good. All right, what else are we looking for? Murmurs, we talked about it. What can murmurs signify? It could be papillary muscle dysfunction. Maybe they just blew through their coronary arteries, or they have a VSD. Okay? All right, it's pretty ominous. All right, so diagnostic testing, what kind of tests are we going to do? What can we do right there at the bedside? Well, we know we have to do an ECG within 10 minutes. Is there anything else we can do at the bedside to help us? Ultrasound, pointed clear ultrasound, a little focus action. What are we looking for? Yeah, pericardial effusion or tamponade, right? Which means right ventricular collapse. If the right ventricle is really dilated, and they had sudden onset chest pain, shortness of breath, what might that indicate? A PE. Very good. Awesome. So we're going to do ECG, chest X-ray, cardiac biomarkers, and then talk about other labs. We're going to look at the ECG and interpret it within 10 minutes. Remember, if there is no ST segment elevation MI, but they have a good story and you think it's evolving and you're really suspicious, repeat the ECG in 10 or 15 minutes. And it's okay. Sometimes they'll come up and they're like, ma'am, did you really need to order a third ECG? I'm like, yes, I meant to do that, you know. And thank you for checking, because sometimes I order stuff stupid, right? I'll order it, and then I didn't see the order, and I thought, yeah, I thought I ordered it, I'll order it again. And that can be bad when we're talking about medications and stuff like that. So the nurses keep you in check, which is awesome. But definitely want to see multiple ECGs if you think something's evolving, whether that be a STEMI or NSTEMI. If there's some little clues that there might be some ischemia on the first one, but it's not that remarkable, and you look at an old ECG and it's not real clear, repeat it in 15 minutes, all right? The more the better, all right? All right, it's a single best test. We talked about it, 10 minutes. Remember, by definition, it has to be ST segment elevation of greater than 1 millimeter in 2 or more anatomically contiguous leads. I know you know that. We talked about it. So that's why I'm flipping through these fast, because you have to know it. All right? STEMI depends on what things do I need to confirm STEMI? What all diagnostic stuff do I need to actually confirm the STEMI? Just the ECG. That's it. That's a STEMI. Okay? Let cardiology do the bedside ultrasound, do all the other stuff. All we need is that initial. That's all we need to confirm it. What do I need to confirm in STEMI? Cardiac biomarker, positive troponin, right? Does the ECG have to show some ischemia or changes? No, it does not. Okay, it's positive biomarker. What about that lady with renal failure who always has a positive troponin? Do I call it in-STEMI every single time she comes in? It'd be nice to have her baseline, right? But what if I don't know her? She came from another facility, but she meets criteria. Hey, in-STEMI, and then let somebody else sort it. An elevated troponin is an independent risk factor for death. So if they have it because they have COPD or PE or CHF or renal disease, it's still an independent risk factor for death. So in the emergency or urgent care areas, if you call something an NSTEMI because they have an elevated troponin and it ends up not being, it's okay, you did the right thing for your patient, okay? An unstable angina we talked about, it's a clinical diagnosis. How are we going to clinically diagnose this? Patient presentation, their history, their physical exam, and you ruled out the other two. All right, good. Know this chart, this is just reminding you everything we've already gone over with the ECGs. What part of the heart is involved? If you see an ECG, you need to know if it's inferior, anterior, or lateral. All right, we're going to talk about those. Which ones are the worst types of MIs to have? Name the number one worst one. And an anterior, because it's an LAD lesion. Okay, what's the second worst? Yeah, maybe septal or really the inferior of the right ventricular, okay? And then what's the most boring one? What's the lame one? Lateral is lame, okay? Because they do well. It's just a tiny little part of the heart. It doesn't take out the whole side. Okay, but they can still die from their dysrhythmias. I'm not trying to minimize the seriousness of a STEMI, okay? I'm just saying of all MIs to have, if you're gonna pick one, that would be the one. Okay, we talked about this already. ST elevation means transmural complete injury. ST depression means what? Ischemia, right? And so if they have an inferior MI, what kind of ECG do we need to do? Right-sided. Okay, good. And we look for reciprocal changes, all right? The larger the reciprocal areas, the larger area of infarct. The more elevation of the STEMI, the more severe the infarct, okay, really bad. And it's higher likelihood of cardiovascular complications and mortality. I was asked during break, hey, if you're sitting on that patient in Brady or wherever you were working and they had a STEMI and you couldn't evacuate them, you're giving them fibrinolytics, what do you do with the patient? I literally sat there with anxiety watching them. And what you do over time is as you're treating them, is you're doing 15-minute neuro checks to make sure they didn't just blow a gasket in their brain. And then you're actually having them on the monitor and you're watching them over time. You'll actually see the ST segment elevation start minimizing and getting better. The patient starts looking like this, instead of this bright-eyed look of doom, they start kind of relaxing a little because they start feeling better. Those are signs that you're going in the right direction. And then the scariest part is they start going into these weird rhythms. It looks like VTAC. It's like, did they just die? And they're like talking to you, but it's an idioventricular rhythm. And T-wave inversions are lastly the things that you see, which show you, hey, this injury has improved and they're perfusing some. So it's a whole thing that evolves over several hours. And those are several hours of my life that I spent very anxious and I can't get back. Okay, so I hope that never happens. So remember, if you see ST segment elevation anywhere, it's a STEMI, as long as it meets the criteria. If you see isolated ST depression in V1 or V2, that's a posterior MI. And before we knew to do posterior MIs, if this was the ECG and it looked like ST depression in V2 or V1, we would do this. You flip it over and look at the delay, it's like, oh, that's elevation, that's a STEMI. That's how Dr. Love and I had to practice medicine, because we've been around so long, her much longer than me, just for clarification, okay? Don't tell me I said it, okay, I'm afraid of you. Okay, but anyway, so this is meant to be the STEMI that we missed. That's a posterior MI, all right? So isolated. So if you see this, in addition to a bunch of ST elevation in 2, 3, and F, that's still an inferior MI with reciprocal changes. If you see this isolated, that's a posterior MI, the one that we're meant to miss. You guys got it? Okay. This is what it looks like to do a right-sided ECG versus a posterior. They just take some of the leads and move them to the back. I am not fantastic at ECGs, like putting the stickers on the people. I know the landmarks and stuff, but if they're sweaty, which they usually are, or hairy, I mean, I don't even know the patients. I'm just like somebody else, you know, like please. And I've become a diva in some of my practice, okay? But the truth is, these, techs and ECG folks that come around and stuff, they're experts at making this happen. The sticky things don't always stick, but anyway, this is what they do, and you just have to sometimes guide them as long as you know the anatomy of where to put it. ECGs, as you know, are frequently misinterpreted, okay? I have never seen a posterior MI, ever in my career. What does that mean? I probably missed it, right? Okay, I've never seen an isolated posterior, so I've been very lucky, or somebody's been unlucky under my care. Anyway, sometimes we'll call it false positive. I've been humiliated by that, and that's okay, because I always advocate for the patient. Sometimes they're non-diagnostic, that's my favorite. The non-specific STT wave changes that don't tell you anything, and those are your in-STEMI people, and you're like, thanks a lot for that. You know, you came in atypical, you have the nerve to present with nausea and vomiting, and then now you have these non-specific changes, and then you popped a giant trope. All right, bottom line, don't rely on the computer. Look at it. If you're unsure, just get a second opinion. And if you're in a facility where you're working with a lot of other providers, other PAs, hey, take a look at this. What do you think? You know, and it's okay. You know, get some, or take pictures of it and send it to the cardiologist that you're consulting right away. Get their expert opinion. All right, definitely want to consult someone. All right, 12 ECG, 12 lead again. We talked about this. We do posterior if we think that there's a posterior MI. We do right-sided if we suspect right-sided. So these slides are long and redundant, right? We've already talked about this stuff with lots of enthusiasm. You guys are fading now because you're seeing the redundancy because other classes have needed this redundancy, but you don't. Did you pick it up the first time? So I just have this as an area that you can go back and refer to, okay? We're gonna talk a little bit about Wellens. Have you guys heard of Wellens? Wellens matters, okay? From what you remember, how do patients present with Wellens? What's the weird thing about Wellens? Give me some stuff about Wellens. Tell me. What's that? Yeah, they can have some biphasic T's depending on what type of Wellens. But what is the thing with Wellens? So, I'm sorry?
The MI is impending?
Yes, they have an impending MI, okay, a Wellens, if you see Wellens signs. So it's associated with a critical stenosis of LAD, which leads are reflective of the left anterior descending coronary artery. Anterior, right? So this correlates with, so this Wellens is widowmaker, okay? So if you miss it, most of them will go on to have an onset of a big anterior MI within 8 or 9 days. So you get one opportunity to see a Wellens if you happen to see it. And guess when they present? When they have chest pain, they don't have those deep inverted T waves. They may have a normal appearing ECG. It's at rest when they're not having pain that they have the deep inverted T waves. Isn't that weird? That's the weird thing about it. All right, here's what it looks like. All right, deep inverted T waves in the anterior leads. This is the LAD. So if you see this, this is a Wellens pattern, all right? They can also be biphasic, as it was pointed out, there's two types. 75% will look like this though. Deep inverted T waves, bad, always bad, okay? I like to classify things as good or bad. This is bad, okay? So you can pick it out? If you saw it on an ECG? Okay, I think you could. For those of you that like little tables, here's some different diagnostic criteria for Wellens syndrome. The best thing is if you see this and they haven't previously had deep T-wave inversions in the anterior leads, you should consult cardiology and consider admission, okay, no matter where you are. If you're in a family medicine clinic, you're gonna say go to the ER right now or have them transported to the ER. If you're in an ER, you're gonna try to admit them to the cardiology team or medicine team for further risk stratification and stuff, okay? All right, moving on. We talked about labs. We already did this. Do I need to go over it again? Does everybody understand the labs that we need to do in the troponin? Okay, good. Do you know that there's a difference in troponins? Yeah, so there's a like regular troponin, there's high sensitivity, there's ultra high sensitivity. Just know whenever, just learn whenever you're practicing wherever, which type of troponin your facility has and what their criteria is. Because some of the criteria is like 0.04. At Bansi, they got the ultra high sensitive troponin, and so it doesn't start getting positive until it's like 15. You know, so just know your criteria and at your facility. And remember that a single troponin and single ECG is not recommended for ruling out an in-STEMI unless it's a low-risk patient and they've had symptoms for at least 6 hours or greater. So if they started having chest pain yesterday, they came in today, you did an ECG and a troponin on them, and they're both okay and negative, it's not an in-STEMI, okay? So we're good, right? Are you with me? You guys get that? Okay. Remember that it takes a little bit for troponin to peak, and then it slowly, over about a week, exits the body. All right. We don't need serum markers for a STEMI. That's a diagnosis we make by ECG. We need troponin for NSTEMI. We need to make sure there's no positive troponin for unstable angina. And then there's still a subset of people who may not be acute coronary syndrome, but they're not low-risk chest pain. They're still high risk for having disease in the heart, even though they're not infarcting right now. And those subset of people, we still have to admit for further workup. So how do we know? We're gonna talk about it. That's why we do the delta or repeat troponin. This helps us kind of classify people into those low-risk categories, all right? All right. Part of the other diagnostic stuff we always do for people that present with chest pain is a portable chest x-ray. Why? Yeah, we don't want to miss that giant pneumothorax, right? Which isn't the best test anyway, but whatever. We don't want to miss anything. We don't want to miss the pneumonia, the cardiomegaly, or the aortic dissection with the widened mediastinum. They warrant a picture, right? If we think that it's a PE or dissection, we're going to do that chest CT specific for that exam. And then if we've ruled out, let's say we've done our 2 tropes, we've done our 2 ECGs, we've compared them. We always compare. So if somebody comes in and they have a chest pain, they're saying this is 7 out of 10 chest pain. I will do the ECG, I'll say no STEMI the time I read it, and I'll say first ECG, like number 1, and then I'll say like 7 out of 10 pain. So then what happens is if at any point in the emergency department that patient becomes pain-free because we have aspirin or nitro or whatever, I'll do a repeat ECG at that time. And then I'll say 0 out of 10 pain, no STEMI or whatever. Why would I want to do that? Yeah, I'm looking for trends, I'm looking for progression of disease, and I'm trying to capture those patients with Wellens, all right? But that's important because it could be dynamic changes is what we call it. Even if they're still having pain, but it's improved, we're gonna do probably a second ECG at some point if they so far haven't met criteria for STEMI or NSTEMI, okay? We'll do a second one just to make sure there are no dynamic changes indicating that they are still trending towards an NSTEMI or some sort of acute coronary syndrome before we put them in a low-risk category. Once we've done that, we've done our due diligence, now, is this patient safe to send home? They're not infarcting right now. I don't think they have unstable angina, but they still could have disease in their heart, right? Who do I send home? Well, we're gonna do a heart score. And these folks are brilliant because they came up with a heart score, and they're like, we're gonna consider history, the ECG, age, risk factors, and troponin. And then like a week later, like, oh my gosh, if you rearrange the order, it spells heart. You know, they didn't intend for it. They didn't make up the acronym to go with heart. So anyway, that's all you have to remember is these 5 things, and you consider it, and if this is evidence-based medicine. So if you apply this to a low-risk chest pain person, then you can decide who gets to go home, who has to be admitted. And what did I tell you? A heart score of whatever or less than can go home? 3 or less can go home. 4 or more, just bring them in. All right? Don't worry about mild, moderate, severe risk. Just 3 or less, they go home. 4 or more, they come in. Okay, this is what the heart score is. And it does require you to know it, or at least look at your peripheral brain for it, and like when you're evaluating the patient, and then assign a point. So for history, we have to decide, is the patient presenting with slightly suspicious symptoms, moderately or highly suspicious symptoms? That's subjective, right? And once we decide how they're presenting, we attach a score to it, right? Have you guys heard this before? Okay, all right, this is important. All right, EKG, is it normal? They get no points. Are they non-specific changes? If so, there's a 1 point. Or do they have depression? 2 points. Why is an ST elevation in this heart scoring system? That's already a STEMI. This is for low-risk people, all right? It should not even be in there. But if you see some ischemia, I would argue that that's not a low-risk patient either, right? They have ischemia, they probably have an STEMI. Okay, anyway, or some sort of ischemia. Anyway, but you get to decide which points. Age matters. Unfortunately, this last year I've moved up. Okay, I'm older than 45. Okay, it wasn't just last year, but unfortunately I already get a point just by age by standing up here. So age matters, less than 45, 45 to 64. If you're over 65, you already got 2 points. All right, so all you have to do is have a slightly suspicious story and be over 65, you know, you're already kind of teetering admission. Risk factors, none, 1 to 2, or 3 or greater. What is risk factors? We talked about it earlier. Smoking, obesity, diabetes, hypercholesterolemia, things like that. So you have to assign a point. And then lastly, we do an initial troponin. This is just based on the initial troponin, not even the delta, just the initial troponin. If it's normal, they get 0. If it's a little bit elevated or markedly elevated, they get points, all right? If it's elevated at all, we're gonna call that an STEMI probably, right? Are you with me? All right, so you tally it all up. If it's 0 to 3, they're low risk. It's up to 1.7% risk. You send them home and say, follow up with your primary care doctor. We recommend outpatient cardiology referral, blah, blah, blah. 4 to 7, you call internal medicine and say, I have this whatever patient with chest pain. I think they have disease. We ruled out acute coronary syndrome here in the urgent care or emergency department, but they have a heart score of 5. They're going to understand what that means, that they need to bring them in and further risk stratify them. Okay? We're almost done. Even though it looks like there's 30 some odd slides left, we're almost done. How much time do I have, Pam?
You've got plenty of time there.
Okay.
About,
Okay.
35 minutes.
All right, good. Hear that, everybody? Yeah, I got used to this longer. Okay. All right, I'm just kidding. Okay, so now we get to the treatment. We talked about how they present, some of the stuff that we're looking for, classic, non-classic. All right, the diagnostic stuff we have to do, ECG, labs, chest x-ray, bedside ultrasound. Now how do we treat them? Okay, everybody, if it's STEMI, we're gonna activate the cath lab. And if we're there, or if we're at a non-PCI capable facility, we're gonna start doing the thrombolytic checklist. We're gonna make sure they've had their aspirin. How much aspirin? Actually, there's a range. More is not always better, so there's a range. As long as they've had at least 162 to 324 milligrams, they're good to go. Anywhere in that range. 1 aspirin's not enough. 2 or more are good. More than 4 is not better. So somewhere between 2 and 4 aspirin, chewable, okay? And then we're gonna start giving them heparin. Okay, are there dosing differences with heparin? How much heparin do we give them? Yeah, you can look it up. Sure. Yeah, you don't want to make a mistake. So typically, ironically, if it's a STEMI, we only give them 4,000 units is the max. If it's an in-STEMI, we usually give 5,000 units. Okay? All right, we actually give less. Anyway, so we're going to give them aspirin, heparin, and nitro if they can take it. If they have the right ventricular involvement of their heart, as long as we're giving them fluid therapy, we can still try to give them a little bit of nitro. I just wouldn't blast them with a 400 microgram sublingual. That's a lot of nitro. Maybe put them on a nitro drip that we can titrate so that we can start trying to interact and minimize that infarct size, but we don't want to make them hypotense, because if we make them hypotense, that means the coronary arteries are not being fed. It means we're worsening the infarct. We're doing the exact opposite of what we're trying to accomplish. So these go low and slow with your nitro if somebody has a right ventricular involvement. If it's just an inferior MI, they can have nitro, they're going to be fine. Or what happens if I'm doing nitro and they become hypotense? Stop it, give them some fluids, okay? I don't jump to pressors, I jump to fluids. Okay, good. All right, so we're going to do all this. IVO2 monitor, these are the things we're doing. Those are the reasons why. Any questions about that? That's how you treat all ACS. The only difference is we may not throw a bunch of nitro at somebody with unstable angina, because they probably don't have chest pain when they're presenting with you. Nitro we give to people with chest pain. If they don't have chest pain, we don't typically give it. Okay? Does that make sense? Kinda? But if they have a STEMI, they're gonna have chest pain, we're gonna give it. All right, recap. So we got some time. We got every minute that goes by that we don't intervene, there's part of the heart dying. So basically you have 90 minutes to do everything you can do as clinicians and then get them to the cath lab. We stop the platelets, right? Why? Because it stops the platelet aggregation and infarct size. Same with coagulation, all patients. We can give them a dose of 60 units per kilogram for STEMI with a max of 4,000 units. Or it depends on which kind of heparin you use, but usually we use unfractionated, or you can give 5,000 units for N-STEMI, okay? That's the max, all right? If we're at a non-PCI capable facility and we have to do fibrinolytics, we need to try to get it in them within 30 minutes, right? So door to fibrinolytics is only 30 minutes. So if we already know we're at somewhere where we can't get them to PCI, we have to make that very important decision within 30 minutes. Can I get them to somewhere within 2 hours? Or can I call cardiology and get a hold of somebody? Or do I, what do I need to do? And so they're not equal. PCI is superior. Fibrinolytics carry a lot of risk. I've seen a lot of patients, unfortunately, not a lot, maybe a handful,
that over time, you know, when they got the fibrinolytics, they ended up with the brain bleed. It's just terrible. You're given a systemic clot buster to try to eliminate one little tiny clot in the heart, whereas PCI is very focused therapy. It has complications associated. I mean, they can blow your coronary artery and you can die, you know, but the complications are much worse with fibrinolytics. So I'm not blasé at all about fibrinolytics. Be very cautious who you give them to, okay? But if you are having to give them to them, you're gonna do it within 30 minutes, okay? PCI is the preferred method because they can put stents in there, they're fenestrated, this is what it looks like, they can do it in real time. They put you on this cool table. I mean, I don't know, I've never been on the table, but I've been in the room. And I may be someday, I don't know. And they shoot dye in there and they can actually see right where the blockage is. So see the big red arrows? This is where there's narrowing or blockage. And the time it takes to eliminate this isn't that great depending on the amount of blockage. So let's say somebody presents with an inferior MI, they take them to the cath lab, but then they see that they have 4-vessel disease. It's going to take them a little bit longer than what they anticipated. And sometimes if there's multi-vessel disease, they may decide to convert that to a CABG. So sometimes these procedures last longer. But just the cath itself, if you can get into the cath lab during phase 2, if you have a facility that does it, it's awesome. Watch it, it's really cool stuff. They shoot the dye, they put in their little stent, it's really cool, and then next thing you know, it's perfusing and everything gets happy. Everybody's happy. We do CABG, or they do it, I don't do it, for multi-vessel disease. And that's especially if they have a significant left main, because left main is bad, right? Or if they have any kind of aneurysms as a complication from the cath procedure itself, or from the major infarct itself. If they're blowing a coronary artery or something, they're gonna have to convert to CABG, okay? Or if there's an NSTEMI with high risk features, they may consider a CABG. What would be an NSTEMI with high risk features? All NSTEMIs have a positive biomarker. So what would be a high risk NSTEMI? Vital signs are vital. So somebody with unstable vital signs, hypotense, cardiogenic shock, even though it's an NSTEMI, their body's not being able to withstand it. So again, STEMI at an outlying hospital, tell me what we're gonna do. STEMI at outlying hospital, meaning you're not at a PCI capable facility. What are we gonna do? I'm gonna say, oh my God, I got STEMI. And then what are we gonna do? Aspirin? Heparin? Nitro, as long as there's no contraindications and there's not right ventricular, not hypotense. All right, then what am I gonna do? I'm gonna call somebody for some help, right? I'm gonna help me, cardiologist, what am I gonna do? And as I'm calling for help desperately, because I have a 30-minute window, somebody, me probably, or my somebody, a nurse, is gonna go down that fibrinolytic checklist. All right, so I'm prepared to do it if I have to, and I'm gonna be consulting cardiology. That's what you're gonna do. Deal? Sounds pretty easy, pretty reasonable, right? And then it's really awesome when you get to consult somebody, you say, per Dr. So-and-so, fibrinolytics withheld, you know, even though transport time is 4 hours, you know? It's the truth. Somebody else is on the hook. They made that decision and that's their expertise, okay? All right, real good. All right, so what kind of drugs can we give? Have you guys talked about fibrinolytics and pharmacy and stuff so you guys are aware of them? Which ones do we use? Which one? Usually Alteplase, yeah. When I was, one of my tours to Iraq, a contractor, you know, they employ these very non-physically fit people as government contractors to be the firefighters of the place that we were at. And so one of them had a massive STEMI, and the only thing we had was TNCase, which is fine. You know, no, we had streptokinase, okay, which we don't ever give now, but that's all we had, so I had to give them that. But anyway, there is risk of bleeding. If it works, so it will restore blood flow about 70 to 80% of that vessel. So by itself, it'll actually clot bust up to 70 to 80% of the occlusion of that vessel. So later, those patients will still go to PCI, but not immediately because they just had clot busters, okay? It's gonna take a while for that to exit the system. And those who receive it within the first couple of hours, actually you decrease their mortality in half. So you're at an outlying facility, let's say you're 5 hours away from the you're doing a remote summer job in Alaska, and then the nearest facility is 5 hours away by helicopter, okay? Sounds like Afghanistan or something. Then you give this, actually you're gonna decrease that patient's mortality in half if you can give it within the first 2 hours. 30 minutes is ideal, but if you can somehow get it in within 2 hours, you're gonna reduce the mortality. Pretty cool stuff, right? All right, what are some contraindications? We talked about this earlier. You don't have to memorize them, it's usually common sense stuff, bleeding stuff, right? What if a pregnant female has a massive STEMI? You can totally do it, right? Yeah. Help her out, help a sister out. Okay, only if they're bleeding, CVA, have a big tumor in the brain, things like that, common sense stuff, or if their blood pressure's off the roof, 220 or whatever, that's probably a contraindication. You have to treat the blood pressure first, and that gets sticky. All right, moving on. Most common complication, what would you think would be the most common catastrophic complication? The brain bleed, and it is catastrophic. It's so sad when it happens, and you know, you just have to have that terrible conversation with the family. I've seen in the NICU ward when I had to do my rotations and stuff. It's just awful. It's an awful complication. So this is not a benign drug. All right, so we just talked about STEMI, PCI facility, non-PCI. Just a recap. What do we do for in STEMI, and you're at a PCI capable facility? Doing the same thing. We're doing aspirin. We're getting a little more heparin, right? No, or do we get less? More or less? More. We get more heparin, and we're doing nitro, same. And then we are going to try to get them to PCI facility within 48 hours. Okay, we're on the hook for that. Okay, whether we're at one already and we just admit them, or we have to transfer them. All right. So why do we give these medications? Well, we talked about aspirin. Why do we give antiplatelets? And a lot of times, in the initiation of the PCI, they'll do dual antiplatelet therapy. They'll do clopidogrel or something else, right? And the reason is because aspirin alone, if you give them nothing else for their STEMI or in STEMI, it will reduce their mortality by 2.3%, just by itself. That's pretty cool. That's better than no percent, right? It does some things. And then alternatively, we give clopidogrel if somebody has a true aspirin allergy. 2B3A antagonists are stronger antiplatelets, so a lot of times they'll initiate that at the time of the at the PCI or at the end, okay? Anticoagulant therapy or antithrombins, that's your, what medicine is that? That we've been talking about. And what's an anticoagulant? Heparin, right? Heparin's the so if you put aspirin plus heparin, you're going to reduce the risk of death by 56% in your heart attack patient. That's pretty high. So we want to give it, right? Okay, and that's the dosing again. I've said it a few times. We usually use a low molecular weight heparin because they have lower protein binding, longer half-life, stuff like that. So it's 6 in one, half a dozen in the other. Like sometimes the cardiologists prefer one or the other. So if you're already talking to a cardiologist and they say, hey, I prefer a heparin, go ahead and put them on a heparin drip and give them the bolus and then a heparin drip. Or sometimes they'll say, no, just give them a 1 mg per kg. Lovenox. So it just depends on who you're talking to, but just know. Nitrates, why do we do it? Because believe it or not, it limits the infarct size. So if you give nitro with somebody, it's going to reduce the infarct size, improve the regional function, decrease the rate of complications, and it makes the patient feel better. This is your pain medication for your heart attack patient. All right, we never thought of nitro as a pain medicine, but it is. All right. It also inhibits platelet aggregation. Did you know that? That nitro inhibits platelet aggregation, like aspirin? I didn't know that either, until I read it on my own slide. I'm just kidding, I had to research it, obviously. Okay, all right, mortality is lowered by 35% with patients that are given nitro. So if we can give it to them, we want to. So now this stuff is starting to stack up, right? We're reducing it by aspirin, the heparin, now the nitro. We're giving this person their best chance, okay? All right. Cautiously, if they have an inferior wall, we already talked about that at nauseum. They're preload dependent. We don't want to drop their pressure. We drop their pressure, they become hypotense. The coronary arteries become ischemic or worsening the infarct size. So how do we mitigate it? We shut it down, give IV fluid bolus. Again, I told you one of the STEMI patients, in-STEMI patients I saw at BAMC when I was doing my cardiology rotation. We literally, within 4 hours, gave that person 10 liters of normal saline. That is a lot of fluid. I have never given that much normal saline to anybody else ever. So that's how much, they weren't fluid down, they were fluid dependent. And so they needed that in order to maintain perfusion. Isn't that crazy? All right, we talked about this already, so I'm gonna flip through it. And these last few slides, you're gonna just love it because it's just gonna be a quick high five, all right? Urgent care, emergency department, we do not give beta blockers. Beta blockers worsens the outcome of the patient. They initiate that 24 hours after the PCI. It's a contraindication now. There is no more Mona B, all right? No morphine, no beta blockers, no ACE inhibitors. ACE inhibitors are initiated after the cath lab, okay? And we never give calcium channel blockers for acute coronary syndrome, unless it's Prinzmetal's, and somebody figures out it's Prinzmetal's. But that's not our job in the emergency department. Our job is to identify the STEMI, call the right people, and then if that patient has a history of Prinzmetal's, then we can have a suspicion of it. If they don't, that's their first presentation, we'll let them figure that out in the cath lab, okay? Everybody with me? Does this make it so much simpler? I mean, this is like, so simple. All right, so complications. What do you think are some complications of a heart attack? Death. Absolutely, that's the first one. I have this like Darth Vader thing I used to remember. Death is the first one. Yes, ma'am.
Maybe like a side rabbit hole. When you're giving patients that much fluid for a few slides ago, are you gonna be concerned about electrolyte abnormalities when you're giving it?
Absolutely, and you also have to worry about flash pulmonary edema and stuff. I'm just saying that particular patient, under the advice of cardiology, required that much fluid because they were so preload dependent. That's how bad their right ventricular wall was just not working. So if you don't have the bucket to hold the blood for the rest of the body, then everything's kind of shutting down and backing up. So absolutely, we don't just willy-nilly hold, hang fluids without any kind of complications. We always worry about, first and foremost, flash pulmonary edema, drowning the patient in all that fluid and causing them to be hypoxic, which is one of the first symptoms of that. They'll become hypoxic and tachypneic. But also, we always monitor their electrolytes, absolutely, and replenish specific electrolytes. A lot of times, these people will have they'll actually have a triple lumen central line, and the reason why they have a triple lumen central line is so we can give multiple IV drips through each of them. Sometimes they're on pressors, fluids, we're giving them magnesium drips, all kinds of stuff. So yeah, all those things are tightly monitored. Good question. Okay, I did not give the patient 10 liters. Okay, B, as a coronary care unit, over a period of several hours, managing inferior STEMI patient gave that much fluid. Okay, so what are some other complications? You said death. That was good. Death is bad. Okay, what else? Yeah, they could come back, right? They could come back a week or so later and have a recurrence, okay? And then a plaque rupture. They could blow an aneurysm. What else?
Wall rupture?
Yeah, they could have a wall rupture. How do we treat that? CT surgery, yeah, and good luck, okay? What else? What other complications? Arrhythmias, I told you, dysrhythmias, arrhythmias, they all have it, and it freaks me out. Like, if I had to be stuck on that patient, it looks like it's V-tach, they're going into like idioventricular rhythms, two-wave inversions, they'll go tachybrady, they look like torsades for a little while, you're like getting all freaked out, so there's all kinds of dysrhythmias. What about a few weeks or a few months after an MI? What's a common complication? Dressler's syndrome, very good. That's a post-MI pericarditis. So all of that can happen. So arrhythmias, they can rupture the ventricle, they can have cardiac tamponade. I remember Darth Vader. When you said death. Death Vader, the same thing, right? He's death. Okay, Darth Vader. So it's death, arrhythmia, rupture of ventricle, tamponade, heart failure, or cardiogenic shock, then you need a valve replacement. The A is aneurysm, Dressler's, embolism, and then recurrence of the MI. Those are all the... Okay, so mechanical complications, if they suddenly decompensate when they were previously stable, something just went bad. They just blew something. Okay, so treatment is usually surgical, so we're going to get a cardiothoracic surgeon on board right away if you have that ability. The free wall rupture happens a lot, especially with those anterior MIs, those LED lesions, and usually 1 to 5 days after infarction. So you're going to know, because you're going to be so smart, they're going to come in, it's like, I just had a heart attack, I was just discharged yesterday, and I have, worse chest pain, and you look at their ECG, it looks like the same, but really they're having an aneurysm, okay, so that happens, or free wall rupture. Usually they'll complain of a different quality of pain, tearing, ripping pain. Treatment is surgical. Cardiogenic shock, that's a complication. How do we treat cardiogenic shock? So we start with fluids, and if that's not working, we're going to go pressors, right? What are our options? Yeah, dobutamine's good. Can we use epi or norepi? You bet. Let's do it. Let's just try to get their pressure up, right? Because the more hypotense they are, and the longer they are, the more ischemic the heart is getting. So we have to support them. We talked about Dressler's. What I want you to remember is that it can happen a couple of days after an MI, but usually it's weeks to months. And we treat Dressler's different from regular pericarditis. So you and me, we just got flu, developed a pericarditis. How do you treat a regular young person that didn't have a heart attack with pericarditis? NSAIDs and colchicine, okay, good. No steroids ever. NSAIDs, colchicine. How do I treat a Dressler's pericarditis? Aspirin, colchicine, okay, no NSAIDs. NSAIDs interfere with the remodeling of the heart after an MI. You give them NSAIDs, you're gonna make them worse, okay, good. You guys know this, you guys are awesome. Complications, no ibuprofen, we just talked about that, makes the infarct get worse. Here's a summary of everything, and everything beyond this are just the pearls that we already talked about. And so the take-home point slide that you already saw, and then your little study aids to help you remember what is anatomically contiguous, okay, just to kind of break it down, and your PALS acronym, okay, to help you. How do you guys feel about that?
Better.
That was a lot of information. It was thrown at you fast, but probably too slow for you, because you guys were quick and you listened fast, okay? Any questions about it? Are you mentally dead? I just fried your brain? Okay, remember PCI. Everybody gets percutaneous coronary intervention, everybody gets platelet, antiplatelet therapy, nitro, and anticoagulation, okay? All right, I'm gonna be able, if you guys have any questions, are most of your ClinCore people starting early? You just do your own ClinCore? You have an absent parent? All right, gotcha. All right.